Okay, I think we're about ready to start, even though some people are still on the coffee break, but we're going to get started because we have a little bit of delay and we don't want to keep you longer than anticipated. So thank you to those of you who did come back from the coffee break. So throughout today, we've been working through the entire cancer care pathway, and in our session now, our spotlight is on holistic integrated care and quality of life for patients. So in this session, actually, I should introduce myself first. I'm Sarah Martin. I'm from Bristol Myers Squibb, and I am an All.Can board member. I'm delighted to be here today with my esteemed panelists on left and right to me. We will introduce them one by one as we go through their interventions. Today, we are going to talk about the availability of skilled healthcare workers and specialized care throughout a well-coordinated care journey. This is fundamental to the effectiveness of cancer care, but also the equity of care. We're going to hear about how this multidisciplinary coordinated care, how it brings efficiency into the cancer pathway and the role it has on improving the quality of life for patients. The themes that we will touch today are on interdisciplinary collaboration, the multidisciplinary nature of quality of life. We're going to showcase two examples from All.Can national initiatives, and one from All.Can national initiative and another from a European initiative. And we're going to talk about how this is connected with the action guide. So cluster 2, coordination of care, but also cluster 3, patient-centeredness. So what really are we talking about when we're talking about coordinated care? We're talking about the specialists from primary care to oncology nurse specialists, cancer patient navigators. We heard so much, such good examples from Leah from All.Can Canada with the spaghetti map, really about how a cancer patient navigation system can improve coordination of care, adherence to treatment, and essentially clinical outcomes. We're also going to talk about multidisciplinary tumor boards, and I don't think we've touched on that yet today. These are groups of healthcare providers with differing types of expertise who meet to discuss cancer diagnosis and treatment of a particular patient and arrive at optimal recommendations. This helps to ensure more comprehensive decision-making, and it also fosters shared decision-making with the patient. And finally, we are going to land on a few calls to action at the end of the panel, as we've heard from the other panels today. So I'm going to start with Caroline Vercher from the OECD. She's a health economist at the OECD Health Division, working on a broad variety of topics related to both data and policy analysis, health system performance assessment, and on the policy side, working with primary care and cancer care.
Thank you, Sarah. Thank you very much for the invitation. So at the OECD, we work closely with the European Commission for the development of the European Cancer Inequalities Registry. So it's an important initiative as part of the Europe's Beating Cancer Plan. This registry is very important because it aims to address disparities in cancer care and cancer outcomes between countries in the EU, but also within countries by population group, so by gender, by socioeconomic status. And clearly the aim is to identify inequalities, but also to address them. So to provide policy recommendation on how to reduce disparities in cancer care and cancer prevention. So it gathers a comprehensive set of indicators covering the whole cancer pathway, from prevention to early detection, treatment, quality of life, to and to palliative care, I would say. And so for the development of the registry, the OECD is developing for the second time a series of country cancer profiles. So we are drafting 29 country reports to monitor performance of cancer care in 27 EU member states, plus Norway and Iceland. And this new edition of Country Cancer Profile will be published next February around the World Cancer Day. So in all this work, we clearly see that incidence is growing across OECD countries and EU countries, obviously. So the most important thing is that incidence will increase over time. So projection shows that incidence will increase by 18% in the EU. But at the same time, we can see that mortality rates from cancer are decreasing. So this is good news related to better early detection, but also improvement in cancer care. And so the combination of increased incidence and reduction in cancer mortality means that in all countries, we can see a growing number of people living with cancer as a chronic condition. And this has an impact on quality of life, on income for people. It has also a large emotional impact, which is associated with symptoms, side effects from treatment. And we show that it has an impact on stress, level of anxiety, and depression. And so an ongoing report at the OECD also will provide an estimation on the impact of cancer on the well-being of patients. And all these results will be incorporated and presented in the country cancer profiles. So it's clearly a high priority to support patients having cancer and those having a history of cancer. So we described a lot of policies around rehabilitative care, use of multidisciplinary team, psychosocial support, fertility preservation, economic reintegration, and so on. So we map all the policies that are being developed in all countries. Thanks.
Thank you very much. That's really interesting. It's interesting to hear that the cancer profiles are including so much information about the patient's quality of life and well-being. And has that always been the case, or is this a new focus?
No, it's a new focus for this edition. In 2023, we had a specific focus on the impact of COVID-19, but obviously the priorities are changing. So now we have a focus on quality of life. And so this new section is based on interviews with stakeholders and on desk research as well.
Excellent, thank you. With that, we're going to move to George Kapitanakis.
Exactly.
Who is the president of the Hellenic Cancer Federation. He's also the All.Can Greece committee chair and the president of the Peria Cancer Patients Association.
Okay. Thank you very much. I want to thank All.Can International for the invitation to be here among you. I am George Kapitanakis. As Sarah said, I'm the president of the Hellenic Cancer Federation. It's an umbrella patient-led organization, has as members 49 associations all over the country, all over Greece, and represents cancer patients and citizens. We are participating in All.Can and developed, created All.Can Greece national initiative back in the end of 2018. And since then I'm there, and I've seen all these years what All.Can does. And I have to say, on behalf of our country, a big thank you, because with All.Can we learn how to collaborate, how to sit all the stakeholders in cancer care around a table and work together. So it was something that helped us a lot during the pandemic, and it is something that I'd like to share with you. I'm very happy about that. So I am a cancer patient myself, cancer survivor, and this experience was the reason that I am here and I am with you. I am volunteer, and my background is in financial economics, and I'm working in financial industry. Here I'm going to give you a small taste, not a lot, about the quality of life. To tell the truth, I was impressed about the macaroni map in Canada. I thought that only in Greece we had this kind of map, but yes, not forget it. Well, here, okay, not work, okay. Well, quality of life for cancer patients is not just about survival. It's about understanding and addressing the multidimensional aspects that affect every individual's physical, emotional, and social well-being. By investigating the quality of life for cancer patients in Greece, where we tried to shed light on the hidden part of the disease iceberg. This is what we believe. Cancer treatments often bring about physical challenges that impact daily life, from managing pain to coping with treatment side effects. The emotional burden of cancer is profound. Patients navigate fear, anxiety, and depression, often feeling isolated in their experience. Cancer affects relationships and social interactions, leading to changes in role support systems and community integration. So why we did this, this study in Greece about the quality of life? The healthcare system is not oriented towards a holistic management of the disease, but is limited to medical approach to the disease, rather than addressing the needs of the person. As a result, many of the above needs you see in this slide remain unmet. In Greece, no study has been conducted to date that addresses the quality of life for cancer patients. And last but not least, we saw it in the previous session, patient experiences and outcomes need to be taken under consideration to design and implement the most effective interventions. To tell the truth, I was one of the 19 that vote that we don't collect routinely PREMs and PROMs in our country, and I can imagine who were the two that do so, to tell the truth. We can see here in this slide the dimensions and the factors that impact the quality of cancer patients. As you can see, there is a lot of job to be done. This research methodology, one slide is okay. Okay, we use three different tools to work and to make this research. And as you can see here, we often talk about qualis, but have we do we know have we defined the word quality good in this qualis? This is something that we have to work on. And here in this slide, you can see in the first diagram above that anxiety and depression are significant parameters reported by patients as very important to them. However, there is insufficient attention and their management is not included in the disease management process. I'm going to run. So here, another very important finding in this study was how much cancer has affected the sexuality of patients. Does anyone talk about that? 2 out of 3 declare that they had significant impact. What are we going to do in this field? What about it? At the same time, it appears that patients' relationship with healthcare professionals are at least exceptional. We can see that about 65% they had a very high satisfaction with treatment, and also you can see in the up and right diagram that they also have a very good satisfaction with the access to cancer care. To tell the truth, these three indicators are better than the satisfaction from the life in general. And this is very impressive finding. Finally, what we're trying to do with this study is to find inequalities. And we see that there are a lot of inequalities here. I choose to show just two of them. The first one is related to the disease stage. As you can see, the non-metastatic patients refer that they have better quality of life than the metastatic patients. And also the people who had, the patients who had a better level of education declared that they had a better quality of life than the people who didn't, who had lower level. So to truly support these cancer patients and survivors, we must address each of these dimensions comprehensively. It's about providing a holistic care that goes beyond medical treatments to enhance mental health support, community engagement, and quality of life interventions. This was some of the findings of this study that we did about the quality of life, because you know, it's a very big study and had a lot of findings. But I think that we saw that we have to do a lot of work in social, in the personal and physical dimension, and also to address the inequalities that we also find in quality of life. Thank you.
Thank you, George. It's interesting to see the satisfaction with the access to care, and yet the dissatisfaction and the impact on the personal relationships and personal life. That's, and indeed, it has to be addressed. Now we are going to move over to the panel on my right side. We're going to hear from Richard Price. Richard is a change in the program today. We were going to hear from a colleague of his who was called away, but we're lucky enough to have Richard with us today from the European Cancer Organization, Head of Policy. And Richard is going to talk to us about the Smart Care project. Over to you, Richard.
Thank you very much, Sarah. And congratulations again to All.Can for the fantastic new action guide. I think it's another great contribution to the suite of tools that have been produced by the consortium and helping push this agenda forward. ECO has been very happy to be with All.Can from the start of this journey, and I think the ethos of meeting these challenges in common is very much also informing the Smart Care project, which I'll speak to in a moment. Europe as well is thinking in that frame of mind about cancer at the present time. We have something called Europe's Beating Cancer Plan and an EU cancer research mission, and together they are producing more than 40 different initiatives across all parts of cancer care, detection, treatment, and also in survivorship. And there are many helpful, useful projects that are, I think, contributing to better patient navigation. I could name a few, such as EU On-Call, which is looking to have common cancer survival quality of life indicators. We have a project called EU Navigate, which is looking at the Canadian experience of patient navigation and testing that in a European context. But this project is one that is coordinated by the European Cancer Organization, and it's really about trying to put cancer survivorship services into the hands, quite literally, of cancer survivors through a mobile app. And it involves more than 40 different healthcare professional, patients, cancer centers, and tech development organizations. And we've been running for about 1.5 years. And I think at the very start of this project, we wanted to kind of root ourselves and took a lot of inspiration from All.Can, in fact. I remember at the beginning, All.Can ran a giant survey across the world, 1,000 patients giving their perspectives on what inefficiency was to them in cancer. And I think that those results have always rooted, as far as I can tell, All.Can's philosophy. Well, we copied you, Eduardo, and we did our own 1,000 patient survey across Europe about what are the sort of things patients would want in an app to help them in their experience after diagnosis and treatment. And the results were really interesting, and that's what sort of grounded us. It's not always easy with EU projects to tell the Commission, well, we're going to do something based on a survey. They want you to say it all up front, but we felt it really important not to do things that the patients didn't tell us were important. So these are the 4 things that we're focused on. Number 1, your health data in your hand, that you can access your data through your phone and take that to the healthcare professional that you want to speak to. If you want to speak to a pharmacist, psycho-oncologist, a nutritionist, that you've got at the touch of a button all of the relevant details that they would want. Secondly, and this again very much coming from what the patients were telling us they wanted, through an app like this, which is EU supported, run by professional societies and patient organisations, resources that they can trust. So we know that the breadth of issues survivors face are wide, complex, from disability to depression and distress, many, many, many things. We also know that there's lots of resources that have been produced and created to help, but we need to help put them together. So that's what the prototype is doing as well. And then the communication with users and their healthcare professionals. So that could be professionals they're already seeing, but it could also be professionals that they've not yet accessed or knew were in their area, be it a psycho-oncologist, be it a nutritionist, for example. And this one was a really strong one from the patient community as well, that we hadn't anticipated at the start of the project, but interaction with other survivors and being able to join groups and share experiences, share advice with each other, and that's sort of social aspect of the app that is being developed too. Some things we thought might be important or were judged less important. So things like gamification, and we got a sense from the patients that's something you can find elsewhere. And this was really to focus on what's unique about an EU and patient-led app. So just before sort of rounding that off, I couldn't resist this slide because I think it speaks so well to what All.Can's all about. Is this is reality in some hospitals. This is a doctor who is involved in the project, very passionate about it, but he wanted to convey this is the basement in his hospital and how they're keeping records, and it looks like something from the 1970s, and that looks a bit like my home office, but we need to sort of put this in the past. We've got supercomputers in our hands. There's no reason that we should be treating patients' records in this sort of way, and all of the risks and everything that goes with that. So we hope Smart Care is one of the contributions towards putting that into the past. And if you'd like to engage more with this project, do join us at the European Cancer Summit in November in Brussels. We'll have a special day focused to understanding the results of the survey, the results of the prototype, where we can go in the future. These are some really inspiring people, very involved in the project, and I think we'll have some very good conversations. Thank you.
Thank you, Richard. Do you want to say anything about the timelines of this project? When is it expected to roll out?
We finished the prototype this year, and then we're relying on the political support to continue. So it's really actually important as well. I might get my call to action in early. We want to see Europe's Beating Cancer Plan and its mission continue. These are fantastic foundations being laid, but there's always a risk with a new Parliament, a new Commission, something else attracts people's attention, and we don't want to see that happen. So I think all of us here have a role in making sure that comes across.
Excellent, thank you. And now we're going to move to Dr. Jan Depter, to my right. Jan is president of All.Can Switzerland and the head of market access and public affairs at Novartis Switzerland. Jan is going to tell us about a study on survivorship for people affected by cancer in Switzerland.
Thanks so much, Sarah. So we heard today a lot of initiatives in order to establish better screening, diagnosis, and access to medicines. So if we are able to be very efficient here and have this all become a reality, then we come about more what we are talking here in this session about what is happening afterwards. And just an example, in Switzerland, a population of 9 million, we had in 2021 226,000 cancer survivors, and in 2024, this year, 450,000 cancer survivors. So this number is growing rapidly. And still, we believe that there is a lot to be done for those patients yet. And because these are patients who have not just been diagnosed, treated, and they go home. These are patients who have a long-term impact because of their disease, because of their treatments. And these are physical impacts, these are psychological impacts, like neuropathy, depression, anxiety, but also the integration back into the work life. So we in All.Can Switzerland, we asked ourselves, what is happening to those patients in Switzerland? There we heard of some activities, but we didn't have a good understanding of what is going on. So we wanted to understand how efficiently is the care for those patients done? Is it efficacious? And is there something what we can do differently? So we set out a research. We started 2 years ago. And in this research, it was classical research with desk research, semi-structured interviews, standardized questionnaires, and we had with a lot of stakeholders involved, and also with all the regional cancer leagues who've done this research. And what it revealed is that in Switzerland, but I believe it's very much also a need in other countries. So the needs which needs to be established or responded to in Switzerland was that, first of all, the provision of care for cancer survivors needs to be target group specific. So it's different, the approaches, if you talk to cancer survivors, to children who are cancer survivors, to adolescents or to adults. Then the offerings need to be holistic. From the medical and psychological and social perspective. Today is more centered about the clinical care. It needs to be interprofessional and multidisciplinary. And it needs to be individualized. So it does not work, and we heard this, the optionality. So the delivery of care needs to be individualized. We need individualized aftercare plans for those survivors. And it needs to be sustainable so that the financing is secured also by the mandatory health insurance. So what we found, what the actual state is in Switzerland, is that it's very heterogeneous, also a bit sobering. We have a lot of regional differences. Of course, we have a federal system, and it's the nature of a federal system that there are regional differences, but they are huge. We found a few lighthouse projects which are very helpful also to demonstrate how this aftercare can be done, but only a few ones where they achieved a truly coordinated care services. But we also found out that there are a lot of initiatives which are not sustainable. It depends often on the person who is initiating the project. And if the person is leaving this initiative for whatever reasons, it's not sustainable, or the funding of an initiative is not, is just for a pilot, and it's not secured for a full establishment. But we also found that all these initiatives are often single offers, that they're not integrated in a holistic way in a plan. So there's a risk. So even if a survivor takes this offering, once the person is done, it's again the risk of falling out of the system. What we also found that from the health policy perspective is not a single canton in Switzerland has a systematic aftercare planning. We know already that it's quite difficult to have a systematic screening in all cantons, but still for aftercare planning there is nothing existent on the policy level. There's also a lack of awareness among the professionals that there's a need for taking care of those persons. And even though if there was awareness, there was a lack of knowledge, what shall we actually do with those patients? So these were all the findings out of the study. And we created also a set of recommendations on various levels, on the government level, the provision of care, on the education research bit, and also on the community and connecting part. And one of on the governing level, one recommendation, and that's something which we have started working on with All.Can Switzerland this year, is creating a framework. Actually, all these single initiatives which are happening can be integrated in a sustainable way. And creating a framework means that we started collecting from the multidisciplinary way, creating a guideline, a cancer survivor guideline for Switzerland, which is holistic, multidisciplinary, and can be used as a framework for sustainable implementation. And after establishing in the consensus way with the stakeholders this guideline, we want to establish this first in a region and then further roll out in the national level.
Sounds excellent, very exciting. And I suppose then you would like to roll that out nationally with recommendations. I think we also heard earlier in some of the earlier sessions about the financial modeling and of the economic impact of what a few small changes could make. And I think this would be very relevant in your program in Switzerland about what a few small changes could make in survivorship and return to work and a person's life in their contribution. Thank you. I believe now we have to go to Mentimeter. So everybody get out your phones. Our first question is, what do you think is the biggest barrier in achieving a good quality of life during or post-cancer treatment? Okay, while we wait for some of the responses to go up, knowing that we are working against the clock here, I'm going to come back to the start of our panelists, so Caroline, and ask you if you'd like to share some examples of best practices, but also in conjunction with that, what would be your call to action that you'd like to highlight for today's session?
Thank you for the question. So there are many good practices across countries, obviously, but I would like to mention first the use of team approach, as it's highlighted in the guide. It's a really important policies to improve quality of life. So in Australia, for example, this is a very good practice that we highlight in our report. Where health professionals work all together to define the treatment plan and also all the support services for patients. There are clear evidence in the literature that it improves communication between professionals, but also with patients and also within the experts. So it's really important to improve the efficiency of the decision making, and it has been associated with higher quality of life, higher patient satisfaction. Across the European Union, it's in growing development, so it's now implemented in a growing number of countries. So this is good development. I would like as well to mention another good practice which relates to economic reintegration, because this is an important dimension which has indirect impact on quality of life and well-being. So it's from Germany. They have some progressive reintegration approach for the in the workplace. So it allows to reduce the workload, it allows to modify the task, and it also allows to provide free training education program on an individual needs. So this is very important, and it's not common practice in the EU, so it should be mentioned. And lastly, I would like to mention another type of policy, which is to support informal carer. It has not been mentioned well today, I think, and this is an important policy, particularly during terminal care. So Sweden here is the most generous country. It provides up to 100 days of paid leave, so for a child, a partner, or a close friend during terminal care. And this is not the common practice again in the EU countries, so it should be highlighted. I will stop there.
Thank you, Karen. Would you, George, like to share some recommendations from the finding of your survey in Greece?
Yes, well, I think that Jan earlier told most of them, to tell the truth. But I have to say that answering also to this question,
Yes.
that in my opinion is health systems orientation and fragmentation. Orientation has to do with the political will to change the way that they face the diseases and the patients as persons, as entities. And fragmentation is that there are operational problems in the healthcare systems. So I believe that we have to invest in comprehensive support programs that will give the opportunity to have a different aspect to the systems and find a way to change. I'd like to mention two examples. We have almost 1 year that in Greece, in one big university hospital, have the survivorship clinic. This survivorship clinic has to manage patients that have finished their treatment, and the doctors there are facing the problems, the side effects, and they trying to support the survivorship of these patients. And the second is that we have another program called Hospital at Home. In this program, we have to do with patients, eligible patients that have mostly mobility problems, and the doctors and the nurses visiting them, their home, and give them, produce them the therapies over there, chemotherapies, immunotherapies, and what is easy to be done out of the hospital and home. So these are two projects, two programs that give us another point of view of how to treat, how to support this patient, and how to improve the quality of life of these patients. So we are working on widening these programs, and we try to ensure funding so we can have them also in other hospitals. This is something that will change all the mentality and the culture of the healthcare system, and I believe that a pilot project or actions like that are what we need to provide the evidence needed on how some things can be changed and be better for the patients.
Excellent, thank you. Richard, would you like to tell us about the pragmatic tools to help patients navigate?
Well, I think we covered one with the Smart Care project, and I think there's many others that one could describe, both from the EU Cancer Plan and Mission and from others. But I think I really wanted to reiterate the reason that we need to my call to action. Yeah, excellent. I think we were expecting a health commissioner to be potentially announced this week, as in terms of the designate, and we all have, if we're members of citizens of an EU country, we all have members of the European Parliament we can be in contact with. So,
thank you. And Jan, your call to action.
So, George also said with the fragmentation of the system, and there's actually a piece of research we have done together with Bettina and Marta about what is standing in our way with the different silos and fragmentation. And one of the maybe not so surprising but very clear outcome was that there's a lack of trust. There's a lack of trust in the system between all the stakeholders. And my call to action would be, and it's maybe like more like Ivana, maybe it's a Novartis thing. It's a call for behavior, not for action. It's a call for leadership on one side to overcome all this fragmentation and for more trust that basically everyone is seeking for is looking for the same goal. No?
Very good, thank you. Madalena, okay, we have one more Mentimeter. Thought so. That we need your answers on. These are all being collated and they will be put into the meeting report. So if you don't mind to please give this one an answer as well.
Maybe just to add here when the results are coming in, also in Switzerland, multidisciplinary tumor boards are well established. Here the thing is when we are talking about the holistic delivery of care and the quality of life, it stops after the treatment. So these multidisciplinary boards are in order to deliver effective treatments to the patients, but then it stops. And that's something where we also need to be institutionalized, how you can expand this and to have a more broader and longer perspective. Yeah?
So in the interest of time, I would like to thank our panelists today, Caroline, George, Jan, and Richard. Thank you so much for sharing your perspectives on how coordinated and integrated care across the pathway and beyond the treatment pathway really can deliver better patient outcomes, better patient quality of life, and better efficiency in the treatment continuum. Thank you very much.
Okay, final rush. Please stay with us. Few more minutes. It's the final part of the day. It's been a long day. It's been full of interesting discussions, informations, full of energy. And I, first and foremost, have to thank all those panelists that have come on stage throughout the day. I have to thank all of you for being so generous with your time and energetic throughout the day. The other thing is that we will close with Christobel after a round of discussion, final round of discussion. And the other thing I have to say from an organizational perspective is that we have now received apologies from the WHO. Raffaella Casolino is unable to join. They have actually a parallel meeting going on, which was supposed to finish an hour ago or so, and it has not finished. So apologies on her behalf. after all, considering a day with 32 speakers, if one drops out, that's physiological. The other, the other important thing that I have here on my to-do list is brief recap of the day, which is clearly mission impossible. And not being Tom Cruise, I will rather focus on one practical thing that happened today, which is the spaghetti map. I think that's the highlight of the day. The spaghetti map became the macaroni map half an hour later. Now, as a southerner Italian, I endorse both versions of the map, but it certainly deserves credit to Leah for illustrating in such a clear and comprehensive way complex issue, or the complexity rather, of the situation that you're dealing with, which is to a large extent applicable in several other jurisdictions. The other thing that I want to highlight is the launch of the action guide. That goes without saying. It's been an important initiative for All.Can during the course of the past 12 months at least. So a special thank you to Sofia, Dionne, and the team from Amsterdam, which made that possible. It is, in my modest opinion, a pioneering project, in the sense that it tries ambitiously to create a framework and at the same time highlight opportunities for action, for implementation of interventions that have got to do with more efficient cancer care. So thank you for that. Once we will have digested all the contents and the recommendations, I am sure that we will have enough work for the next 5 years on that basis and in a very coherent, or within a coherent strategic framework. The final thing is that we should be looking at 2025. And besides the joy for being together today, and besides the very important feedback, input, considerations that have been raised today, we have to start looking at 2025, what's going to make us as a community relevant, impactful, meaningful, and also how do we keep contributing to move the needle for cancer patients and for better health outcomes at large. And for that reason, so looking into 2025, we wanted to have two of our colleagues from within our international community, All.Can community, from Colombia and from Romania. I'm going in alphabetical order for diplomatic reasons, and have also a touch of how do you envisage your priorities in 2025, clearly based on the work that you have done so far. So I pause here. I will first perhaps ask Miguel from Colombia to start, and then Simona, you go next. And then Cristobal will close the day. Thank you.
So thank you, Eduardo and Cristobal, for this invitation. I'm glad to be here in order to let our community know what is happening in Colombia with All.Can and all the work that we have been doing in that country with the support of All.Can International. So thank you for this event. Thank you for all the support during these 4 years. And it's remarkable that we are arriving to a 5th year in Colombia with our initiative. So we are proud of being part of this network. Thank you to our sponsors, mainly to Bristol Myers Squibb, that has been from the beginning on with us in Colombia. And thanks to other sponsors such as Stellas and such as Sanofi that have been working with the initiative in that country as well. So first of all, I want to introduce what is going on in Colombia with All.Can. We have been working there for almost 5 years. From the beginning on, we are lucky because we were able to articulate a coalition with a multi-stakeholder platform. So we have support there from the government, from patient groups, medical societies, the academia, as well as the industry, as I mentioned before. So from the first year on, we have a table of decisions, a committee that is committed to work with our projects there, and it's the unique, so far, multi-stakeholder initiative composed of these different agents that I mentioned before. There is no other initiative in our country with this composition. And I think that that's the beauty of our initiative there, because we are able to work together around our purposes that we have in All.Can, such as the purpose of educating on efficiency on cancer care. We have been working there with different initiatives in order to introduce the concept. In that country, before All.Can, the arrival of All.Can, there were not knowledge on efficiency on cancer care. And that was the main reason because of the government decided to support the initiative. They wanted to be educated on efficiency on cancer care. You remember, Dr. Matt, that you were in the phone with the representative from the government to talk on efficiency. Thank you. Because thanks to that type of support, they were convinced on working together with All.Can because they saw a different value. They saw an asset on how to grow up in that country with efficiency on cancer care. And based on that interest from the government and from other agents in the system, we decided to run different initiatives, such as papers, forums, webinars, and different activities in order to educate the different ecosystem on efficiency on cancer care. And now we have a system there that is aware on efficiency and eager to work on an applied project. And that's going to be the future, Eduardo. You ask about the future. And the future is going to be related to how to apply a project locally, a pretty concrete project on how to move forward with that knowledge that we got on efficiency. And we are lucky because within the coalition in Colombia, the leadership comes from the National Cancer Institute. That institute belongs to the government, and they have been, they decided to work with us on different initiatives, and they are proposing a project for the coming year, for 2025, in order to improve the quality of the treatment in different types of cancer with need of facial prosthesis. And that's maybe, perhaps, is going to be the project related to efficiency on cancer care, that concrete project that we decide that we wish to have in our country. On the other side, let me tell you on the surveys, because I think that we are lucky on having resources, financial resources, to run 2 surveys in our country. The first in 2021, and the last one in this year, in this current year. We just conducted that second survey in order to identify those gaps related to efficiency. And in order to produce some key recommendations on policy, because one of the key objectives of All.Can in Colombia is how to shape policy in our country in order to improve our law and our norms. And we conducted this second survey, which is the largest patient survey within the country. And we're proud of that title, because it's not easy to have that title in the country. We have several surveys related to cancer treatment and to cancer diagnosis, but we are the largest one focused on the patients in number. We gathered 1,200 patients within this survey, this last survey, which is bigger than the first one. And we encompasses different type of cancer with this survey, and different regions, urban and rural areas, in order to see what are the gaps, in order to see what are the opportunities and the challenges that we have in the country related to efficiency. And I wanted to share with you some of the key findings related to efficiency in Colombia. So, for example, the one related to time to cancer detection is good, that finding, because time to cancer detection improved, with most cases being diagnosed between 1 and 3 months. In other words, most of our patients are within that range of time. Between the first and the third month, they become diagnosed. And the other good finding is related to the increase in the number of patients that are being capable to finish their treatment. According to the survey, 5% of the patients are improving in their capability to finish the treatment, which is good. However, there are relevant opportunities that we identified in the survey in order to improve the efficiency process, which is our main objective. So, for example, we have 50% of denials of patients experience service denials or delays. In other words, half of patients are suffering delays or denials, which is bad. Something is happening behind that figure. And there is an opportunity to improve efficiency, I'm sure, with the same resources that we have. That is our purpose. We don't promise the government to get more money in order to improve. Our promise is related to improve with the same amount of resources that we have currently within the system. The other bad finding is the one related to the use of legal instruments. Because of the different barriers and constraints that we have in our system, most of the patients, or a big amount of patients, have to use legal instruments, mechanisms, in order to ensure their diagnosis or treatment. And according to our survey, the use of legal instruments rose by 14% in treatment, related to treatment, and 6% related to diagnosis. In other words, Colombians are using more legal instruments, mechanisms, in order to ensure their diagnosis or treatment in cancer. And then, finally, the perception of treatment efficiency declined, because we have a question related on the perception that patients may have on efficiency. If they perceived or not that the system is improving or not efficiency in cancer care. And in 2020, that was our first survey, 81% of patients rated their treatment as very efficient, 81. And now, 74% in our recent conducted survey tend to think that their treatment is very efficient. So we have a lot here, and we have to discover, and we have to work with the patients' groups in order to see what is happening behind that perception and why. And we have some details that are already depicted in the survey in order to see what are the causes of that perception, in order to work with All.Can on how to improve the different indicators, KPIs that we have within the country, within the system, in order to improve the perception and efficiency. So at the end of the day, we are lucky because we have data. Somebody talked today about the importance of data. We have some data in Colombia, according to our survey. It's pretty credible, our data, because it's well endorsed by different agents within the system, but mainly by the National Cancer Institute that belongs to the government, as I said before. So we have data that is credible and that is well perceived within the country. And now in 2025, we are trying first to take advantage of those data in order to work in our applied project on cancer, on efficiency on cancer in Colombia first. Second, we're going to be producing some recommendations for the government in order to shape policy, because we're in a moment in Colombia when the government is trying to transform the healthcare system. So it represents an opportunity for us to introduce data and recommendations to shape the policy that the government is producing.
Thank you. Thank you very much.
Hello, everyone. I'm very happy to be here, and I want to thank again to Eduardo and all the All.Can international representatives for their invitation. We are here for the first time. All.Can is existing in Romania since 2023, so it's quite fresh. And we have been the 21st country to join the network. And actually the sixth to conduct a survey, a patient survey, and this has been done in 2023 as one of our first initiatives. What All.Can aims to do in Romania is to increase efficiency in the resources in cancer care. So what we are trying to do is to position ourselves as a reliable partner to the decision makers in the healthcare in Romania. And of course, we want to bring focus on the importance of improving the efficiency in cancer care. So the initiatives that we have been running in 2023, as I said, is this patient survey that then was has generated a white paper with the conclusions and with recommendations based on this survey, which was presented at the Parliament in the presence of all our key stakeholders. Very important, this white paper was also a very comprehensive overview of this oncological system in Romania. And one important thing that we would like to mention also about Romania is that we are the first country in the European Union that has been it's implementing national control cancer plan, which is aligned with the European Cancer Plan and with Mission Against Cancer. Further on in 2024, we are now focusing on a plan, a comprehensive plan to also improve the efficiency of the resources in oncology. This is something that we are doing by delegating it to an external expert. The data has been collected, and now we are collecting the feedback from our members. The resources that we are looking at are the existing ones that need to be optimized, but also the purpose is to have the resources also to look at the resources so that we can see how they can be reallocated or supplemented so that the patient pathways can improve. Then what will happen as a next step? We are going to have technical debate, which is a very important aspect considering the challenging context that we are now passing through in Romania from the elections point of view. Of course, by the end of this year, so this autumn, we are going to also have some meetings with the decision makers in healthcare so that we also can get input from them. One other important thing that we need to mention here is the expansion of our network in 2024, as we have 2 members. We have started in 2023 with initial poll of 9 members. Now we are 11. The National Society of Oncology in Romania has joined as a scientific partner, and RayScape RX as an AI powered radiology platform is our new knowledge partner, and we think that this is a very significant progress that we have made after only 1 year since we have been on the market. So in 2025, what we are going to do is to focus on disseminating the recommendation in the studying the analysis that we are now running, because it's very important to get to all the governmental agencies and to the all relevant parties, considering the changing political environment, as I said. Second thing is to also focus on having and ensuring that we get stakeholder engagement, because we need their support in order to implement our initiatives. Then, of course, what we need to do is also to assist with implementation, because we need to assess, to track progress, to assess how things are going, and of course to see how changes need to be done. Of course, some media engagement will be necessary in order to also amplify the message and also to help us with to give the support for the initiatives that we are doing. And last but not least, we need to enhance the local initiatives, and this is something that we need to do, and we are doing by, of course, having all the know-how and integrating all that we can from the global network. So now we are looking at some approach which is comprehensive and optimistic, we might say, considering all these steps that we are now talking about. As I said, about the recommendation, the key recommendation implementation, ensuring stakeholder engagement, having media on our side, and also ensuring implementation. And as I said, what we are counting on is on gathering all that know-how that we can from the global network. And this is once again why I want to thank you for having us here. And we are counting on everything that we can get and integrate as insights, as best practices, and as guideline from the international organization, in order for us to be able to have a significant impact in cancer care in Romania, and to transform cancer care by being in Romania a valuable resource and, of course, a partner, as I said, valuable partner to the decision makers in healthcare in Romania. Thank you so much.
Thank you. We've got a couple of minutes, and I just thought it's great to hear what you want to do in the future. I just thought I'd bring things back before we close up to the action guide that we heard about today. And just for your amusement, really, in Australia, we decided we'd try and put some of these metrics into practice and see what some of the problems were. Now, we couldn't do that at a national scale yet. We've just released our National Cancer Plan. So I thought, well, we'll try and do it at an institutional level, see what it's like measuring those metrics. And we chose breast cancer because I'm a breast cancer doctor. And we chose the institutions I work in, which is the only national cancer hospital, the Peter Mac Cancer Hospital in Melbourne and Royal Melbourne Hospital. So I just thought I'd go over these 8 metrics and tell you what we found so far. And this is a work in progress. So some of them are pretty easy to sort out. And I'd imagine they would be either a national level, institutional level, or whatever. Time to diagnosis. Reasonably easy, you know, from when the patient first has a symptom or goes for screening to when they actually have their tissue diagnosis of a cancer. Primary care interval was a bit tricky because that really means having integrated data from general practice from when the patient first had a symptom and how long that took for them eventually to get there. And because we have very bad data that goes into general practice, it's hard actually to find that. Percentage of cancers diagnosed through emergency, a really important metric for some cancer. Thank goodness in breast cancer it wasn't. So we've got around 600 new breast cancer diagnoses, and I think we've only had 1 that came through ED, fortunately. Time from tissue diagnosis to treatment, again, that's a fairly simple thing to work out, although for some cancers it's quite hard. Some of the hematological malignancies, lung cancer, you know, the first treatment can be quite difficult to know when it is, but reasonably easy to collect that data. And we have national guidelines on what that should be. We have things called optimal care pathways, so we were able to match that to those quite well. Percentage of patients who receive chemotherapy in the last 14 days of life, again, fortunately, in my area, in breast cancer, we've only had, with all the patients' data we collected last year, I've only had 1 death that we know of. So we haven't really needed to collect that data. Percentage of patients having seen a clinical nurse specialist, and I thought that was going to be dead easy. You know, all of our patients see clinical nurse specialists. We have we're, you know, the premier cancer unit in the country. And yet when we actually drilled down into the data, it was really hard to find that. And so far, only 60% of our patients have got documented that they saw a breast cancer nurse. And I was shocked by that. I'm sure they must have done. And our nurses said, oh, we probably saw them by telephone rather than in person. But it's actually a lot harder to do than you think. And we have an electronic medical record, and every health professional should put something into that. The last 2 were very tricky, however, patient experience and patient involvement in decision making. So for patient experience, are we routinely collecting PROMs? And we weren't one of those 2 countries. I don't know who you were, but we weren't one of those who routinely do. So we're working out how to do that routinely, but we don't at the moment. But there are other ways, of course, that we do collect patient experience. But patient involvement in decision-making is actually a really hard one. And it's going to be interesting about the metrics that you put around that to work out how you do that. So we've got a little team looking at how they can do that, either into the future prospectively using ways of actually measuring decision-making and how the patient is involved in it, or just going through notes. And then the one that we have added to these 8 metrics was around equity. I mentioned, I think, right at the beginning how important that is to us. And we have, in our population, about 45% of our patients at Royal Melbourne Hospital come from a non-English speaking background. We have 170 languages spoken. And of course, there's all the other measures of equity. So we thought, what should we do? And so we've used a simple one, which was, were you able to access an interpreter in your outpatient clinics if you needed to? And around 25% of our patients had no English as a first language. And I can't tell you yet how many did access an interpreter, but it's certainly not going to be 100%. So that just gives you a bit of a snapshot at an institutional level of how these metrics can be put in place. And I hope that you found that a bit interesting, and I hope that you'll start to see some challenges. But I do hope that you'll use this, because I think this is a fantastic document and a fantastic guide for us to really look at how we can start to improve efficiencies wherever we want to. So for the last couple of minutes, it really just remains for me to say say thank yous and say what we're doing in the future. We've had as Eduardo said, we've had so many fantastic learnings today. I've got pages written down of things that I've learnt and things I want to take away. But what we'll be doing is using those calls to action to really try to plan what All.Can's going to be doing in the next year, and very much to work with all of you, both the All.Can national initiatives, but also all of our other stakeholders who've come together. So I'd first like to thank all of you here and online for coming, and those who are going to be listening to this in the future, and for your really important contributions. You're helping to shape what we're going to be doing into the future. And then finally, some thank yous as well. Thank you to our board members who've been here. Thank you to Eduardo. And thank you to the fantastic team, to Angela and the amazing Madalena, who's sitting in the corner, who's made all of this work. I hope you've enjoyed the day. I certainly have. And I'm looking forward to the rest of this week at the UICC meeting. Thank you.
Thank you.